Assalamu alaikum wa rahmatullahi wa barakatuh. Dear brothers and sisters, we are delighted in the Saudi Society of Men's Health to bring you a new episode of our educational activity. This is our 7th episode, and today we are shifting the gears and talking about something touching every person in the medical field, whether a physician or non-physician, related to the medico-legal litigations that any one of us can be at one point at a point of question. For those of you who are joining us for the first time, this activity is being organized by the Saudi Society of Men's Health, which is a society under the umbrella of King Saud University. The society had been established in 2018 and concerned about all issues related to men's health, medical or surgical, metabolic or psychological. And for those of you who would like to have more information about the society, please feel free to contact our contact information as shown in the slide in front of you. We're happy to receive any questions through our emails or through our social media channels. And for those of you who would like to come back and view this webinar or other webinars that have been conducted through the umbrella of Saudi Society of Men's Health, you can also subscribe and review our previous episodes through our YouTube channels. And I advise anyone to subscribe so he or she can have up-to-date information for our activity. Today, it gives me the pleasure to introduce our panelist, Dr. Ra'id Al-Mani', who is a consultant urologist and andrologist from King Saud University, Faculty of Medicine. He is also a member of the Saudi Society of Men's Health and a member of the Legionary Committee at the Ministry of Health. Also, I'm very delighted to introduce Dr. Khalid Al-Ghamidi, Assistant Professor of Medical and Civil Law, and also the Acting Vice Dean at the Faculty of Law, King Abdulaziz University. I'm sure by end of today, you'll have more deep understanding of how the medico-legal system runs in the country, how to avoid a date in the court, how to protect yourself, as well as how to protect your patients. So at this point, I would like to handle the mic to Dr. Ra'id to start his first part. Meanwhile, tell Dr. Ra'id, get ready for this. I would like just to explain how the webinar for today will be running. The first part of the webinar will be conducted by Dr. Ra'id Al-Mani' to give you a brief introduction about the medico-legal system in the country and how medical litigations run and some advices to stay out of trouble. And the second part, according to the allocated time, we'll start having some few cases. Actually, they are not real cases, but they are very similar to real cases that have been encountered. And we will tell you how the things started to be unfold from the beginning of the medical problem till the verdict of the court. And what are the things that support the decision? What are the things against the decision? This is in collaboration with our panelist, Dr. Khalid Al-Ghamidi. Tell Dr. Ra'id.
Dr. Saleh, yes. You can hear me?
Yes.
Okay. So it's a great pleasure to present this webinar. Usually these sessions are heavy and sometimes boring, but I promise you during this webinar, it will be focused and entertainment as much as we can. This is my affiliations. I'll start with this slide. Nowadays, passengers of airline companies demand transportation from point A to point B with no interruption, although some circumstances are out of the hand, like weather. It might lead to decrease in satisfaction and probably increase in the complaint rate. And in case of disaster, the first person that will be investigated is the pilot. Same applies to medicine. Nowadays, patients demand treatment without any adverse events, which is a very justified demand, but no treatment is without possible complications. And there is a confusion in the general population about the definition of a complication and a medical error, which probably increase litigation against physicians. If you look at these terminologies, probably most of you know all of them because we use them in hospitals and M&M committees during audit process. But these definitions or these terminology are usually not used within the court walls. I'm gonna just go run them very fast. Adverse events means an injury due to the treatment rather than a complication, which is an injury due to the disease itself. Near miss is an error in the treatment, but didn't lead to harmful event either by chance or by active intervention. Medical error is an error either in planning or executing treatment, and sentinel event when a serious event happens like organ loss or death. What is usually used in courts is whether there is a medical error present or not. And sometimes it's classified to malpractice and negligence. Malpractice is the act of commission without intent, while negligence is the omission, also without intent. Now, to have a clear medical error against a healthcare worker, you need 4 elements. First, and these elements has to be established or proved by the patient. First, there should be a duty of the healthcare professional toward the patient, and this duty has to be breached and has to cause a damage which is measurable. And these 4, if it's fully proven by the patient, then there will be most probably act against the physician, as we will see later. Now, some of you noticed some variation on acts against healthcare workers, although the events seems to be similar, but there is a variation, and this variation, in my opinion, mainly by some factors that I'm gonna list. The first factor is the physician. If the physician has multiple breaches of his duties, probably each time the act against the healthcare worker will be escalated. Also, it depends on the patient. It has been established in the literature. For example, pediatric patients has the highest compensation rate. Also, it depends on the hospital where the event happened. If there is multiple violations of policy and procedure, it probably will escalate the act. Also, it depends on the error itself. What do I mean by the error? Let's take an example, a patient who has a penile prosthesis and got an infection. Physician A did a proper treatment for the patient, gave proper antibiotic, the patient urine culture was negative, but there was a breach in the consent. Physician B had a good consent, fulfilled the consent, but didn't give preoperative antibiotic and implanted the patient while he has a UTI. Probably the event that happened is the same, which is infection, but the act will be different depending on the error that happened. If you allow me just a slide of wisdom, no practicing physician is immune to litigation. What do I mean by that? Even if you apply the best safety measures and the best clinical standard and the best documentation, although this is the goal of every healthcare worker, it doesn't mean that no litigation can be filed against this healthcare worker. I'm going to give you some numbers, and these numbers actually from the Saudi numbers, and we have wrote a paper about it, which will be published soon. If you look at the total number of lawsuits in Saudi Arabia, you can see a gradual increase in the total number. You can see 2017, 2018, 2019, there is a gradual increase. If you compare last year, which is 2019 to 2001, you can see that there is a 242% increase in litigation, which is a huge number. If you look at the health sectors where litigation were against, usually you can find the private sector is the highest. If you look at specialty, the gynae is the highest, followed by dentistry, and you can find that the urology, it's in the lower spectrum, and in the North American literature, urology is considered moderate risk, where usually physicians have an average of 2 lawsuits per their career. This slide is very important because it delivers one important information. If you look at the bar and you see the bar represents the total number of lawsuits per specialty. And if you look at the yellow color, it represents where the physician has to pay compensation to the patient, while the purple color represents that these cases were in favor of the physician. You can see that there is a big percentage of cases where there was no clear reason for litigation, which reinforced the fact that no physician is immune to litigation. Now, what are the causes of this increase in litigation? No one knows, because there is no actual studies or to show what is the reason for the increase of litigation. But I'm going to brainstorm you with some causes that could contribute to this increase in number. Is it because of increase in population of Saudi Arabia? Maybe it contributes, but if you look at the year of 2001 and compare it to 2019, probably the population has increased 7 to 8 million and doesn't explain the increase of 242% in litigation. Could it be due to healthcare services where the waiting times are long? Probably, but not confirmed. Could it be due to social media? How do they handle medical news? Maybe, but also not confirmed. Is it due to news and article targeting healthcare workers? Maybe, but also not confirmed. Remember, when a lawsuit is filed against a healthcare worker, he will be audited. What do I mean by this slide? Let's go to the same example where a physician implanted a patient with benign prosthesis and he developed an infection. Let's say that this physician did the best practice for this patient and all his steps were accurate and complete. Still, there is a chance that this physician will have a disciplinary act if his license is expired or if he works in a place where he is not allowed to work, or if his clinical privileges are not updated. Now, let's go to the flow chart of the process from the beginning till the end. Now, if you look at the blue part of the slide, it's the steps of each step of the process, and in the white area, which is the lower part, it's the negative or the issues with each step. So let's take it one by one. First, the patient will file a complaint either through his hospital or the Ministry of Health. The issue with this step is that any patient can complain without filtering system, even if it was personal reasons. Then the authority in the second step will come to the health institute and will take a copy of the file. And the issue of this step is the chance to falsify. We have seen a patient who denies the signatures in the consent, and it's very difficult to prove or disprove these things. So probably this can be solved by electronic signature and electronic filing. The third step is investigation, where investigation is done with the physician. And the problem with this step is usually the investigation is done through people who are not medically trained or doesn't have a medical background. So some questions which are relevant are not asked, and probably some question which is irrelevant is documented. Then the file is compiled and sent for an expert opinion from the same specialty, where he studies the file and writes his opinion. The issue with this is that sometimes you need more specialized people in certain fields, and the bias is not eliminated because the name of the patient, the name of the hospital, the name of the physician appears. And the third problem with this step is that it's a paper format, so it makes it difficult to handle the documents. Then the file after this step goes to a committee. The committee is formed from a judge and 3 physicians, where they review the file. And the problem with this step that the physicians usually are from different specialty. Sometimes there is missing items that has to be requested. Sometimes there is wrong lawsuits where the patient has filed a lawsuit against the wrong physician or healthcare worker, and the process has to be repeated. Sometimes it's also difficult to communicate with if there is a missing items, because it has to go through the official channels. Then a court date is set where the patient comes and the healthcare worker, and the issue with this step is that there is a delayed appointments usually. Then a decision is made, and the issue is usually it takes a long process. There is no physician protection against personal lawsuits. There is some issues with disability evaluation, and the biggest issue with this is there is no classifications done to the medical error that happens. So there is no, we can't conduct root cause analysis in these cases. One of the most important part that is breached is the consent. And if you go to the literature, the breach in these consent that lead to an act against physician ranges from 20% up to above 50%. I'm not going to go into details about this. I'm going to just put one slide, but if you want reference, you can go to the guide of the Ministry of Health, which was established last year. It's a very detailed guide and very nice guide. The important steps in a consent is to discuss with the patient the diagnosis, the procedure with non-technical term, the adverse events. All these are usually done properly. But the fourth step is explaining to the patient the benefit of the procedure and the harm if he doesn't do the procedure. What do we mean by this? If the patient comes, for example, with a bladder tumor and you ask for him to do a TURBT and he refuses, this next step is not to sign against medical advice. You have a document that you explain to him if he doesn't get treated, probably the disease will progress. The fifth important step is to inform the patient about alternative option. What we mean by this, even if in your center, if an option is not available, you have to inform the patient about the acceptable alternative option. Example for this is a ureteric stone. If you are working in a center where only shockwave is available, you have to inform the patient about the alternative therapy, which is ureteroscopy, which is the best treatment, even if it's not available in your center. Now, every healthcare worker, his priority is patient safety. And this is part of our work, and it's more important than avoiding litigation. But avoiding litigation is important because it consumes the healthcare worker time, also put him in physical stress, and sometimes also lead to limitation in resources. Some of the Western countries has developed resolution programs where if there is a medical error or if there is adverse event, usually through this program, they handle it either by communicating with these patients or by compensation, which is much less than what happens when it goes to courts. The increase in number of litigation has resulted into what we call defensive medicine. What is defensive medicine? It's a deviation from the sound medical practice to avoid the threat of malpractice litigation. It has some upsides and downsides. The downside of defensive medicine, it leads to more consultation, more investigation, more intervention, more radiation, and more costs, which strains the healthcare system. But it has some upsides like better documentation, better communication, and better audit process. Now, in case of an event, not only in medical error, in any event, even if it's adverse event or complication, anything, the strategy that healthcare workers should apply is disclosure, sympathy, apology. By these three things, probably by literature have proven that it will reduce the complaint by 43% and will maintain the relationship between the healthcare worker and the patient. If the healthcare worker engage in a confrontation of the patient, probably the motive of litigation will change to personal motivation, which is probably the worst motivation. After this, if there is a lawsuit, you have to inform your insurance company and be prepared. The quote that we usually hear is learn from your mistakes, but in medicine, it might cause you your career, repetition, guilt feeling, physical and psychological stress. Although it's somewhat harsh to say this, but it's better to learn from other mistakes by reinforcing feedback from audits and root cause analysis. By this slide, I finish my talk. Thank you very much for listening.
Okay, thank you, Dr. Raed. Very informative and concise presentation. And I hope this have shed some light on the principle of medico-legal litigations and how to avoid putting yourself in troubles. Now we'll go to the second part of this presentation, which is some case studies. I have to confirm again, this is not real life cases, but these are very similar cases to cases encountered in the court. And as the times allows us, till we finish our allocated time by 10 p.m., we will try to give you the story from the beginning and how it's unfolded. I would like first to welcome Dr. Khalid, and if you can just open your mic, and if you have any comments that you'd like to add to the previous part of the presentation.
Bismillah ar-Rahman ar-Rahim. No, I have nothing really. Dr. Raed, he presented very, very interesting points. And let me start with the terminology here, because we will use that more than one time in the cases which follows. So civil liability and disciplinary liability and criminal liability, usually those kind of liabilities happen when a doctor or let's say a health professional committed medical error. Normally, for civil liability, when doctor committed a medical error, so when the patient asks or seeks compensation, in that case, we can say the doctor has committed an error. Depends on the outcome of the court judgment. This is something else. But normally, civil liability, there is no intention to harm the patient, and the patient requires compensation for the error. The criminal, we will go to the third one, then come back to the second one. The criminal liability normally happens when a doctor intentionally either do something against the act, especially LBHB, or committed any crime against the patient. The disciplinary liability, it's a kind of let's say, to trial the doctor or to trial the professional healthcare for doing as well, violating the LBHB, but not usually with let's say, sometimes it may occur with the civil liability, sometimes it may occur without the civil or the criminal liability. So the doctor, for example, may take a photo of the patient and send that photo to someone else. There is no harm to the patient, and there is, let's say no crime in that case, but the doctor has doing something against the act in that case. Sometimes, usually disciplinary liability comes together with the civil and criminal liability. So this is in very simple way.
Great. So just for those of you who are not familiar with the LPHP, if you can just add some few headings on the law, Dr. Khalid.
The LBHB 2005 is an act which regulates the health profession, not the healthcare system or something else, the health profession, not only for doctor, but for all health professionals. There was an act in 1998 before, and it was for doctor and dentist, but this one is for every health professional in Saudi Arabia who has obtained a license from the Ministry of Health. So all of them has to act according to the LBHP. The act has considered many area. First of all, the license. Second, the doctor duties against or the doctor duties to the for the patient, sorry, and the doctor duty for the health in general, and at the end of the act, talk about the legal liabilities, which cover all the area in that case. So be careful with the act. You have to know about this act. Really, it's very important to know the patient rights based on the LBHP.
So it is the law for professional health practice.
Yes.
Every healthcare practitioner or professional have to know about this law. It's available at the Ministry of Health website. So everybody can go and download it free of charge and keep it as a reference for him. So now the third and last part of this presentation is to talk about some cases. We will start by the history of the case, then we will end up by the law point of view in the case. So the first case is for a 45 years old male who have erectile dysfunction, who visited his urologist, and the decision was to do for him a semi-rigid penile prosthesis. And for those of you who are not familiar with this, when a patient is complaining of erectile dysfunction, sexual dysfunction, and failed all medical treatment, usually we go for surgical and operative solutions. And there are two solutions. You have the semi-rigid penile prosthesis and you have the inflatable penile prosthesis. Each one of those should be discussed with the patient, and the ultimate decision should be a joint decision between the patient and the physician. But in this case, he was offered a semi-rigid penile prosthesis only. The operation itself went uneventful, so there was no problems. Later on, the patient came back complaining that he's not satisfied with the prosthesis. He don't feel that it restored his erection. So this case went to an expert for opinion. An expert, for those of you who are not familiar with this, is a subject expert. So he knows about the disease and the available treatment options. So the experts have reviewed the file and came back with the statement that the patient was not informed about the inflatable penile prosthesis, which is the second option. The file also went to the audit committee, who usually review the file for documentation in terms of consent and medical documentation, and they found no documentation of complete informed consent related to this case. The final court decision was there was a breach of informed consent. So the decision was not in favor of the physician. Dr. Khalid, what's your opinion on this?
This is one of the most important case, really. Usually, doctors tell the patient about the point of view from his perspective. You need to tell the patient about his case and about the available options from the patient perspective. So some patients may prefer, let's say, option A, even in medical opinion. No, option A has less function or something like this. But the patient comfortable with his choice. So the doctor has to tell, and this is the act which says, has to tell the patient not only about the one option, it's about all the available options, and leave the patient to take the right one for him or for her in that case. So don't put yourself on the patient's shoes. No, you need to tell the patient about the available options and leave the patient to take his decision in that case. What you think it's very proper for the patient might think not. For example, if you don't tell the patient about the seriousness of his case, for example, and he want to defer the operation 2 or 3 days, so if he take this decision because you didn't tell him about the seriousness of the cases, his case in that case, this is another violation of of Article 18. So in that case, you have to tell the patient about the seriousness, and if he, for example, takes 3, 4, 5 days to make his decision, that may cause him more harm. So you need, as we say before, to tell the patient not only about one option, but all the available options, and leave the patient to decide which is the best one from his point of view, not from your point of view.
Okay, that's very well explained. So the take-home message from this case: do not decide for a well-informed patient.
Yeah.
You have to lie down all the possible options, and you share the decision with the patients. But do not act as if the patient is having no capacity to take an action. Yeah. This is frequently we can encounter it in our case. Can you just go back to the first case, please? Because some of the surgeons, and for example, in sexual medicine or urology, they know or they are expert in one type of procedures, in one type of intervention. They are not expert on the other alternative or newly introduced options. So according to him, I don't know only that option. I know only that option. That's why I put that option in front of the patient. But in front of the court, this is not an excuse. You have to bring the patient all the possible options. And if he decided to go for option that you are not expert in or you're not familiar in, you have to refer the patient to that expert person. So the statement is very clear. Do not put yourself in the patient's shoes. Thank you. So we'll go for the second case. We already have a lot of questions coming on in the Q&As, and encourage all our participants to put down their questions, and we'll try our best to answer them by the end of the webinar. So the second case for a 35-year-old male who came complaining of a stone in his right upper ureter. So for those who are not aware of the possible treatment options, there are multiple ways of treating the ureteric stone, including shockwave lithotripsy, ureteroscopy, laparoscopy, open surgery, which is something old and not practiced anymore. So this patient underwent ESWL, but he failed. And after that, his physician decided to go for open stone retrieval. So he opened him up, incision, removed the stone. Patient have a post-op complication of wound dehiscence because of the wound incision. This case went to the expert who knows about the technology and the disease spectrum and the available treatment options. and according to the expert opinion, what had been offered to the patient, which is the open stone retrieval procedure, was not the standard of care. So the audit committee also have looked into the file, and they found that this patient lacked the available tools in his hospital. And the court decided in favor of the patient. The physician have committed a malpractice. What is your opinion from the legal point of view, Dr. Khalid?
In this case, as long as you don't know how to use the tools or how to use the, let's say, operational procedure, do not do that, because in this case or in the similar case, you'll be liable for violating Article 27. So the patient will possibly will go for trial and will ask for compensation about that. So my advice here is as long as you know how to use the medical device or how to use the operational procedure, do that properly. If you don't know, don't do that, as long as it's not an emergency cases. So if it is normal case, do not exceed your limit. Do not do something you are not familiar with.
Okay, great. So the take-home message from this case, we are in the kingdom, alhamdulillah. We have a state-of-the-art centers. If not available in your city, it will be available in other main cities. And the treatment, especially the surgical treatment when it comes to the urology field, have been advanced very much. New tools have been introduced and will be introduced every day, that to decrease the patient complications and increase the success rate. So that patient in this case failed shockwave, which is the initial treatment. It might be an acceptable treatment, but if this failed, that physician should not do open treatment, because next door there are physicians who have the tools to treat him without opening him with less complications. So again, avoid troubles, do not do any heroic measures, and refer the patient to the center of expertise who can treat him with the minimal side effects and better success. Okay, thank you. We'll go for the third case now. So this case is for 65 years old male with erectile dysfunction who have been trying medical treatment for some times, but he failed with the oral medications. Somebody mentioned to him that there are something called stem cell therapy for erectile dysfunction. So he went to that physician and he received the treatment. Now, after the treatment, patient came back with no substantial improvement. So there was no success in terms of therapy. He still have his erectile dysfunction and he's still unable to perform his function. So the patient was satisfied. On the other hand, there was no treatment-related side effects after the stem cell therapy. So this case went to the expert, and who decided that this stem cell therapy is not an approved therapy. And the file have also been transferred to the audit committee, and they found there was no problem. There was an informed consent, and the documentation in the progress note was enough. With this, the court decided that there was a breach of executive regulations and decided in favor of the patient. So why this is happening, Dr. Khalid?
Okay. Article 7 is prohibited, let's say, to conduct or to perform any kind of operation or any kind of, let's say, diagnosis or something like this. It's not, unless it's proved in Saudi Arabia. This is another problem here because, for example, we have the Food and Medicine Authority here in Saudi Arabia. So you know which kind of medicine is legally can be used. But the problem is with the operational procedure. There is no, let's say, there's no authority which can approve either A or B procedure is accepted in Saudi Arabia and can be applied. The act itself put two kind of measures. First of all, is any kind of operational procedure or diagnosis that is not approved by scientists, for example. And the second part or the second measure, it's about any kind of as we said before, operational procedure or diagnosis that is prohibited in Saudi Arabia. So my message here is be aware of any new kind of procedure if you can apply that to the patient or not in Saudi Arabia, if that is approved or not. The big issue here and the naked questions, as they said, is which authority or which is in Saudi Arabia which can state that is approved procedure or not. And I will leave this question for Dr. Saleh to answer.
Well, that's very important because,
yes,
you know, according to the Act, to the Health Professional Act, any experimental treatment or procedure or medication is prohibited. Now, when it is not experimental but not approved for practice, the guidelines in the international reputed guidelines, and also locally by now we know the authority to authorize medications for use under the borders of Saudi Arabia is the Saudi Food and Drug Administration. There are sections for drug and food, and there are sections for instruments and machines. So unless this is really approved, you are putting yourself at stake. And if there is even if there is no side effect from the treatment, but if the patient is not satisfied with the treatment, he is at the right to sue you and file a lawsuit in the court. Okay, I guess the message is clear here. Let's go for the next case, please. So this patient is a 25 years old young male who was diagnosed with a Fournier gangrene. And for those of you who are not familiar with Fournier gangrene, this is an emergency bacterial infection. It has to be dealt with as soon as it is diagnosed, because delay in the treatment will affect the patient life, but not even the function of his limb. It can affect his life. So the key aspect here is a rapid diagnosis and rapid intervention. Now, unfortunately, this patient was not treated because he is not eligible for treatment in the hospital where he was presenting. This is ended up by patient death. So the patient family claimed against the treating physician that there was a delay in the treatment that led to the patient death. So this case went to the expert opinion, who reviewed the case, and his conclusion was there was a treatment delay. The same case went to the auditing committee. They found no problems in terms of documentations and progress note. Patient was not admitted because of the eligibility issue. This case went to the court, and there was a clear breach of the executive regulations according to the Healthcare Act. So the decision was not in favor of the physicians, although the patient was not eligible for treatment. What's your take on this, Dr. Khalid?
The issue here is about as well unproved operational or diagnosis procedure. And as well as we say in Article 7 and in Article 8, the case itself, it depends whether it's let's say, an emergency case or it's a normal case. The doctor in such case has to at least provide, let's say, the essential or the basic treatment for the patient, and in such case they need as well to not leave the patient because
eligibility issue.
Yes. So you can't, for example, especially in the case of emergency, you can't leave the patient without any treatment. You need to provide treatment for the patient in such cases, if I understand the case properly.
Some people might ask, actually, this is one of the questions that came up in the Q&A, since we are talking about emergency treatment. Now it is clear, the law is clear here, whenever there is a life-threatening or limb-threatening condition, treatment have to be offered in any hospital, whether governmental or private, regardless of the eligibility. Later on, the hospital can claim the patient or the Ministry of Health to cover the cost. The question now, if the physician would like to treat the patient, but his hospital refused the admission, whom to claim here?
This is another a big issue, because the whole act only talks about the health professionals. It doesn't talk about the health institutions, whether private or public sector. And I really prefer, because sometimes I, as a doctor, in the hospital, I'm for example, I'm going to operate in the patient, but the hospital doesn't provide the proper equipment for doing the surgery, for example. So it is my problem or the hospital problem in that case. Should I be only the person who will be held liable for the error or for the harm which the patient will which occur to the patient, or should the hospital as well be a part of that? Really, this has to be addressed. A hospital or any health institutions has to, in such cases, to be liable for the error happened or something like this. It's not sufficient, and it's not clear now in the Act, in the LBHB. It's only talk about the health provider or health professionals, but it doesn't talk about the health institutions. For example, in some cases, as I said before, the doctor might not be the cause of the harm. It might be the equipment which the hospital provide. It's not very good for doing the operation or something like this.
Great. So this is just to remind our colleagues in the healthcare profession, try to protect yourself from everybody surrounding you. You have to write a clear documentation in your notes that you would like to admit the patient, but there was some administrative issues preventing the patient from receiving the treatment. So you have to be clear, very well documented in the patient file, because what is written is what will be read. It's not important just that you thought about it or you have verbalized to the patient and the patient family without documentation in the chart. Again, what's written is what's counted on, not what verbalized. And you can notice in any case that we are bringing here, when it comes to the legal action, we are referencing the court decision to the Article 7, Article 8, and other articles. This is related to the Healthcare Act that we referred to earlier. Okay, so we'll go for next case now. So this case is for a 60-year-old male patient who had a prostate cancer, for which among the treatment options is to undergo prostatectomy, and one of the treatment modality is robotic prostatectomy. The operation went uneventful, but the patient came later on after a few months complaining of erectile dysfunction and urinary incontinence, which is, for those of you who are not familiar with with this disease spectrum and the treatment offered, erectile dysfunction and incontinence is a possible complication after prostatectomy, whether open, laparoscopic, or robotic. Now, this file went to the expert, and his opinion was clear. Although these complications are possible, but the physician who performed the surgery was not qualified to do a robotic prostatectomy. This case also went to the auditing committee. They found no issues related to the consent or the documentations or the patient progress in the hospital. Finally, the court decision was in favor of the patient. There was a breach of the executive regulation. So what is your opinion on this, Dr. Khalid, for a physician who is performing a surgery or an advanced procedure and he is not qualified or trained to do this?
First of all, the Act, the LBHB 2005 is clear. You have to have a valid license to practice health professions. So even you have thousands of certificates from different schools of medicine, you will not be able to practice medicine unless you have a license. So this is the first thing. Even the license, it doesn't mean you are protected from liability. Sometimes you have a license, but you may obtain this license by false certificate or something like this. The second issue is to stick with your profession. Do not exceed your profession unless, as we said before, in an emergency cases. Okay, this is the first part. The second part about the Article 9B, as we said before, do not exceed your specialist or your specialist in such case. Yes, your qualification, unless, and I'm saying that several times, unless it's an emergency cases. So in that case, you can exceed your specialist. And as well as we said before, do not do something unless you know about the procedure, unless you about the case of the patient. Do not do fantasy, for example, and say, okay, I can treat it A or B or C cases. No, please stick with your specialist. Do not do something over it unless, as we said, it's an emergency cases. In that case, yes, you can be not tried, but be careful. Even you think this thing will not harm the patient, no, you exceed the limit and you breach the act in such cases.
Now, I have just to add in this. Now, with the new regulations of the Saudi Commission for Health Specialties, they are adding all the specialties and subspecialties in your license when you apply for recognition. So attending a course for a week or 2 weeks will not make you an expert. Really, you have to go through the proper channels in obtaining a certifying practice, either by a fellowship or mini-fellowship, whatever is acceptable in the specialty community. Because as you can see here, all of you, that all those cases ultimately will end up by expert opinion, and that expert who is usually specialized in that field. And usually the court respects the expert opinions in most of the time. So doing a training for a few hours or watching a movie or a training online course will not make you an expert in very advanced procedures. We're not talking about simple procedure that comes here and there. Like this procedure is a robotic prostatectomy. It really needs a good learning curve to master the procedure and to avoid and to know how to deal with complications. Now, before we proceed to the second case, probably the last case, I have to ask also Dr. Khalid, because one of the questions that came up here, what about litigations that happened before issuing the license from the Ministry of Health and the Saudi Council? suppose a patient is coming from abroad to practice in one of the governmental hospitals, and they ask him to perform procedures before he obtained the final license. So if there is a complications or a medical error happened during that window before he got the final license, would be he at a fault, or is that something that can be overlooked?
I know, as we said, the act is clear in that you have to have a license before you practice medicine. During the examination by the Saudi Commission for Health Specialists, if you have the temporary license, that means you can practice. But if you don't have a license, or your license is expired, and you haven't renewed the license, any harm to the patient, he will be compensated, but the insurance company will not pay in this case, because it's your fault to not renew your license. If you don't have a license, let's say you just finished your School of Medicine course and you signed a contract with any kind of health sector, suddenly you start to practice medicine. In this case, you committed not only a civil, let's say, litigation, but a crime, because you are practicing medicine without a license. And this is a very serious, let's say, crime, because the cases now is transferred to the public prosecutor, then to the criminal court in such cases. So the patient will receive a compensation. The doctor will be held liable for that.
Okay, one question related to the same case here, or probably a similar cases. Let's say that the physician is expert in that procedure, but the procedure was done by the resident who is under the training by that physician. The physician did not actually attend the case, but he relied on the resident to perform the procedure in the operating room. So if there is a complication happened, which one will take the main responsibility? The performing resident who performed the procedure and got the complication happened, or the primary physician who admitted the patient under his name?
It's difficult to answer these questions, because as we said, normally the case will be reviewed by experts, and they will evaluate both of them, the causation for the harm, whether by A or B. But in any cases, if I am the specialist, and let's say I am asked the nurse to close the wound or to do something, it's not his or her job at this operation. So in this case, I will be only the responsible person in that case. So normally what happened now, for example, if I am a doctor and there is a trainee, and I ask him to close the wound or something like this, or to do the stitches. In such cases, I am from my point of view, I am the only responsible person for that, because I am the one who has to conduct this operation and to finish this operation. Unless it's under my supervision, this is something else. So if I am there, I am present, and I'm saying what is doing, this is something else. But if I just ask him to do that and I leave the operation theater, no. In this case, I am the only person who will be responsible for that. But as I said, this is from the point of view of the of a lawyer, but from the point of view of the health, the Sharia health panel, I think it will be something else, because they will evaluate the act based on the expert in such cases.
Yes, I do agree with you, because the consultant is the ultimate responsible person for this. And he is responsible for his patient, and he's responsible for the acts of his training residents.
Yeah.
Training resident is not a fully qualified physician. So although residents also have a malpractice insurance, but the ultimate responsibility is for the primary admitting team. So his acts are counted on his primary consultant. The consultant have to supervise the resident in all aspects of the procedures, whether a small or major part. Okay, we'll go for next case. So this is for a 45-year-old male who again have erectile dysfunction, for which he underwent inflatable penile prosthesis, which is the more advanced prosthesis usually given for a surgical option for patients with erectile dysfunction. The operation itself went uneventful, but there was a complication later on, happened after a few weeks from the surgery. The prosthesis got infected. So the patient filed a claim. This claim went to the expert whose opinion was there was no issues and all the precautions have been done in the proper way. And the auditing committee found in his files that the physician have promoted himself as an andrologist. At the same time, he's not classified by the Saudi Commission for Health Specialists as an andrologist. And for those of you who are not familiar with those terms, this part of urology, which is the general term for the science concerned with the male genitourinary system, that the people who are specialized with this advanced type of procedure are the andrologists. So this patient did not have an extra classification or extra specialty to classify him as an andrologist. He's just a general urologist. So the court decision went into the favor of the patient. There was a breach of executive regulation. And I think this goes to our previously discussed case. What do you think, Dr. Khalid?
Yeah, it's similar, but as I understand the case, it's the doctor in this case deceived the patient, and he says, "I am a specialist in A or B or C." He's a licensed. He has a proper license in such case, but he's not a specialist in doing the such operation. So he deceives the patient in that case, and this is a kind of which is prohibited in Article 10 from the LBHB, is to say or to use an title or something like this, which is not related to the doctor himself, or he doesn't obtain any kind of certificate or proper training or something like this, but just he wants to. I really use this word, and I mean it when the doctor deceives the patient, or say I am is a specialist in A or B, and he isn't. So this is a kind of applying or using title which is not belong to the patient. Which is not belongs to the doctor, him or herself in such cases.
Great. So the Article 10 is clear in this. Any physician who promotes himself or advertise for himself or claim something that he is not entitled to or not classified to is at the fault. And whenever there was a complication, he is really in a bad shape, because he is not entitled for what he is advertising himself for. This is clearly prohibited in the Saudi regulations. Okay, do we have any more cases? Okay, so I guess probably this is the last case. This is for a 25-year-old young male who has a history of infertility and diagnosed as a varicocele. And for those of you who are not familiar with varicocele, those are dilated veins in the scrotum, and they are known to be a main cause for male infertility. So the patient underwent varicocelectomy. Operation itself was uneventful but complicated by wound infection. So the patient filed a claim against the physician that I got a complication. This file went to the expert, who found that this procedure was not indicated, because when he goes back into the patient evaluation, that varicocele was not a clinical varicocele, it was only a subclinical varicocele, which is why most of the guidelines are not indicated for treatment. At the same time, the auditing committee found no issues. There was a proper informed consent. With this, the court have decided that there was a malpractice because the physician have done something not in the best of the patient interest and not a recognized remedy for infertility, as the varicocele is not a clinical varicocele. So what's your take on this, Dr. Khalid?
This is one of the most important, let's say, action the doctor might do, and he isn't sure about it, because sometimes, okay, I will do procedure A because it doesn't harm the patient, or the harm and the benefit is similar in such cases. So I will do it in such case. No, don't do anything which against patient best interest or doesn't provide any kind of benefit to the patient. If you are going to do or perform something on the patient, make sure you are doing that for the best interest of the patient. The LBHB is really very clear in this thing. The whole thing, the whole procedure, the main idea of the LBHB is to provide a treatment, or is to treat the patient for his or her best interest. Do not measure that in a way because it doesn't have a harm or something like this. And if I do it, it will not harm a patient, but it's not necessarily. So do something it's necessary for the patient and in his best interest. Do not exceed that, and do not just use it because it's less harm or the benefit and the harm is similar in such cases.
Okay, great. Do we have any more cases here? Let's have some questions here since we have a lot of them. Some of the questions, and I would like to ask also Dr. Raed to join us in the discussion here. There was some comments about the medical errors are most of the time related to anesthesia and hospital-acquired infection and delayed diagnosis. I do agree with this. One of the question here is related to the judgment of when there was a verdict that the surgeon or the physician have done a mistake by the court. What would be the spectrum of compensation, Dr. Khalid?
Still now in Saudi Arabia, you have to pay what we call in diya, or blood money in such case. So this is what will the patient receive.
This is in case of death.
Naam?
This is in case of death.
Yeah. But even in, for example, if the patient instead of sorry, I forget the word in English.
If he lost a limb.
No. Yes.
But he lost a limb.
Yes, in that case, there will be a blood money for our diya for
that organ.
For that limb, yes.
For that organ.
Yeah.
Now, what will happen if there is no side effect, but like the stem cell therapy, there was no harm done for the patient, but the patient lost his money for nothing? What would be the usual compensation here?
Normally, I think the patient has to, or the medical institution or whatever is it, has to pay back the patient money, his money. For example, if they put me in the hospital for 3 or 4 nights, if they ask for several kind of CT scans and X-rays and different kind of examination and all of that, it's not necessary. So in this case, I have to have my money back in that cases. But
Sorry, Dr. Khalid, go ahead, please.
Yeah, no, I'm saying something just about the insurance, because the insurance company normally it has to pay only for the private right, or what we call al-haqq al-khas. So, for example, if the doctor committed a crime, or the doctor make any violation for the LBHB, and he has to pay the compensation for that, the insurance company will not pay in such cases. Only for the patient loss by an error from the doctor. This is the only way, or the only thing that the insurance company will pay for.
So the usual system that goes here in Saudi, whenever there is a lawsuit and there is a verdict against the physician or the healthcare practitioner, there are two rights. You have the public right, compensation, and you have the private right, or the private compensation. Yeah. The private one, as what Dr. Khalid have said. What about the public rights, Dr. Wright?
Well, I'll just add something in the civil rights. The civil right, which is in Arabic, al-haqq al-khas, sometimes it exceeds a year. In terms, if there is a disability, it might reach to millions in case of brain death. So it's not limited to a year. It's not limited to 350,000. It might reach to millions.
Yeah.
The thing in Disciplinary Act is usually one of three: either 10,000 compensation, or warning letter, and sometimes withdrawal of license. And we have seen this, where they revoke the license of physician if the act or the breach was so
gross,
so big. Yeah, so gross, so big. Like example, resident is opening a clinic in a private without any supervision, or acts like this, which shows that this physician or healthcare worker is not suitable to practice in the future.
There are a lot of comments here in the Q&A indicating that for those physicians who are usually training residents or medical students, they have to be really under supervision. You have to follow what they are writing in the notes, because sometimes they can put you in the corner. What's written in the documentation is what will stay in the court, what the judge and the expert will look at. So it is their right to have training, and it is your duty to supervise them and protect them and protect yourself. One of the questions here is, what if the patient agreed to receive an experimental treatment? If the patient came, you explained to him, this is not a standard of care, this is an experimental treatment. There are some few articles or papers indicating the benefit of this treatment, and he signed the consent. Later on, he came back when he lacked the improvement, claiming that you deceived him. So how would you look at it from the expert point of view, Dr. Raid, and from the law point of view, Dr. Khalid?
For the experimental treatment, there is a special consent, and has to be through IRB. And there is actually a special law for it. So the normal consent is not enough. If you want to do experimental treatment, it has to be through IRB, through a special consent, and following the special law.
Great. Yes. Any further comments, Dr. Khalid?
As Dr. Raid said, but as you said before as well, documentation is the most important. So write down every single word or thing the patient says.
Maysoon Al-Daham is asking here, how much should we write? Most of the time, we counsel the patient, but we don't document the details of this counseling. So how far would it have to be detailed? Question for both of you.
From my perspective, sometimes there is, by your judgment, you can know this area will be a gray area. So try to write down what.
And you know, this patient might be a troublemaker.
Yes. But really, yes, you can't write everything down. You will have to have like thousands of pages to write down every single point. But the most important, before the procedure or before the operation, try to write down all the complication and the area which you think the patient will rise, or this area will rise, and issues. So try to write it down in case of any kind of trial in the future. But and this is the most important, some doctors left that without anything: the patient name, age, and capacity. And this is the most important. The patient must be with full capacity to consent to treatment or refuse the treatment.
Okay, that's great. And actually, the questions just keep going on and on. I think most of them have been addressed, and for those other questions that have not, because we're running out of time, we will answer them and send them to the corresponding attendee who sent them. To this end, I would like to thank our panelists, Dr. Khalid Al-Ghamdi and Dr. Raed Al-Mini, for such a great presentation and case discussions. We tried in this presentation to not only to touch the theoretical part of you, but also to give you some hints from similar cases encountered in the medical court. This activity had been accredited for 2 CME hours, and those people who attended with us will receive, inshallah, their points through the Saudi Commission for Heart Specialists directly to their account. There will be no certificate for this, but the accreditation of the 2 hours will be counted for all people who attended the whole webinar. We are happy to receive any further comments, questions through our communication channels. You can visit us on our Saudi Society of Men's Health website. More informations related to men's health will be available there. You can send us a direct email or through our Twitter account. And this webinar will be, inshallah, recorded and will appear in our YouTube channels. In addition to previous webinars, for those of you who are interested, you can visit our YouTube channel. You'll find it, inshallah. This one will be, inshallah, available within 2 days. So thank you again for all attendees. We exceeded the 550 attendees for tonight's webinar. We promise you, inshallah, to stay with you, bring you up-to-date informations and what matters you as most. Thank you, and we will conclude the webinar at this point.
Thank you.